Welcome. I'm Jeff Resnick, Senior Historian here at the National Library of Medicine at the National Institutes of Health. Thank you for joining us for today's NLM History Talk. NLM's History Talks promote awareness and use of NLM and related historical collections for research, education, and public service in biomedicine, the social sciences, and the humanities. NLM History Talks also support the commitment of the NLM to recognize the diversity of its collections, which span 11 centuries, encompass a range of digital and physical formats, and originate from nearly every part of the globe. Moreover, NLM History Talks foreground the voices of people of color, women, and individuals of a variety of cultural and disciplinary backgrounds who value these collections and use them to advance their research, teaching, and learning. We supplement NLM History Talks with speaker interviews on our popular blog, Circulating Now, located at circulatingnow.nlm.nih.gov. I'll add that NLM History Talks are made possible by an outstanding team here at the National Library of Medicine and at NIH VideoCasting, and I want to thank each and every one of them for their time and their talent in bringing this program to you every year. I also wish to thank them for helping me orchestrate the Q&A following today's talk. In this regard, I'd like to call your attention to the live feedback button under the video stream you're watching. Please use this feature to send questions to me, which I will then share with our speaker during the Q&A. Today's program, like all of our talks, is being live streamed globally, and it will be archived by NIH VideoCasting for free access by anyone, anywhere. This access is made possible in part by a generous gift to the NLM by the Michael E. DeBakey Medical Foundation. And it's that gift which, in 2016, helped our institution establish the NLM Michael E. DeBakey Fellowship in the History of Medicine. The fellowship provides up to $10,000 to support research in the historical collections of the National Library of Medicine, which include the papers of Dr. Michael E. DeBakey, reflecting the diverse areas in which he made a lasting impact as a legendary American surgeon, educator, and medical statesman, from surgery to medical education to healthcare policy and much, much more. You can learn more about the NLM DeBakey Fellowship simply by Googling NLM DeBakey Fellowship, and you'll find the program page at the top of your search results. The gift of the DeBakey Medical Foundation also makes possible this portion of the NLM History of Medicine lecture series, the annual Michael E. DeBakey Lecture in the History of Medicine, offered by a selected fellow based on her or his completed research in the historical collections of the NLM. So today, I have great pleasure and privilege of introducing Dr. Ogechukwu Williams, Associate Professor in the Department of History at the University of Buffalo, and a 2022 Michael E. DeBakey Fellow. Dr. Williams is a historian of medicine in Africa with particular emphasis on maternal and reproductive health, childbirth, indigenous medical knowledge systems, and medical cinema. Her publications on these themes have appeared in book chapters in several journals, including the Journal of African History, Social History of Medicine, and Journal of African Art History and Visual Culture. Driven by the desire to provide historical backgrounds to current maternal health issues and debates around women's reproduction, Dr. Williams' first book, entitled Birth Politics, Colonial Power, Medical Pluralism, and Maternity in Nigeria, which is forthcoming from Johns Hopkins University Press, explores the local, colonial, and contemporary politics of childbirth and how the British colonial government, medical missionaries, Aladura faith healers, traditional midwives, and international population control organizations sought at various times to advance their agendas through contests over birth and motherhood. This book is the first comprehensive history of childbirth in Nigeria. Dr. Williams' second book project, entitled Dying to Bring Life, A Social History of Maternal Deaths in Nigeria, builds upon her first book and uses oral histories, annual medical reports, anthropological reports, newspapers, legal proceedings, and Safe Motherhood reports to examine the historical contexts of maternal deaths and the ways in which long-standing cultural behaviors and political decisions in colonial and post-colonial Nigeria have impacted maternal deaths since the 20th century. Today, Dr. Williams joins us from the University of Buffalo to present aspects of her research in the NLM collections through her talk entitled Assailed at Home, Champions Abroad, The Push of the American College of Nurse-Midwives for Maternal Healthcare Advancements in Nigeria. Dr. Williams, a warm welcome to you, and we thank you very much for joining us today.
Thank you, Jeff. I'd like to start by thanking the National Library of Medicine team for working with me over the course of several months to make today possible. And thank you everyone for taking the time on a busy Thursday to listen to this lecture. I'm going to start with a brief commentary on how I started this research and ended up with the title that I did. And then I will discuss briefly the origins of the American College of Nurse-Midwives and their special projects section, which I'm going to refer to throughout the talk as ACNM and SPS respectively. And then after that, I will discuss ACNM projects in Nigeria in details and end with a commentary on their attempts to begin special projects at home. And you're going to hear me saying midwifery a lot. I haven't gotten around to the US version of that pronunciation, which is midwifery. So bear with me. I began my research on my second book project in fall 2022 on maternal deaths in fall 2022 and spring 2023 at the National Library of Medicine. And I was interested in their collections on Safe Motherhood initiatives, especially collections of the ACNM and one of their foremost sponsors, the US Agency for International Development. Now, at the archives, instead of requesting the specific folders that I needed, that had the documents that I wanted, I actually requested the entire boxes that contained those folders. And so I spent that visit in the fall just going through just ACNM records, and I had to return in spring 23 to look at the other documents that I was interested in exploring. But what this did for me was that it provided for me an in-depth knowledge of the nature, the extent of ACNM work abroad, but it also provided insights into the political context that they were navigating, at home in the United States, the maternal and reproductive healthcare crisis that they were navigating, as well as questions surrounding their autonomy and the extent of their practice at the time that they ventured abroad. So these two newspaper clips on the screen pretty much summarizes the history of midwifery in the United States. But before I go into that, one of the questions that I began to ask after I saw some of the background surrounding ACNM work abroad, I began to ask, why did ACNM venture abroad at the time that they were still looking for firm footing at home? And that's how I ended up looking at that title, Assailed at Home, Champions Abroad. Now, these two images on the screen, the two newspaper clippings, is an excellent way to summarize the history of midwifery in the United States for most of the 20th century. Beginning in the early 20th century, midwifery was a profession under assault. There was a move, especially by the American Medical Association and the American College of Obstetricians and Gynecologists at the early 20th century to outlaw midwifery. And these were organizations that were predominantly male at the time and white. And so the medicalization of childbirth involved their move to take over normal deliveries, which at the time had been under the control of midwives. Now, by the 1930s, 1940s, they were largely successful, but there was a crisis when it came to maternal health within the United States, especially as a result of that move to criminalize midwives, because there was a crisis of maternal deaths which affected the Black community and communities of color, immigrant communities, which provided the higher number of midwives in the United States during the earlier part of the 20th century and before that. But there was also a crisis of personnel. There were not enough doctors to provide maternity services to women across the country in the United States. And this crisis was even worse in rural America. Now, a new class of midwives emerged to fill in this gap, this personnel gap, and these were became known as the nurse midwives. These were nurses that began to practice midwifery and began to train, receive some training in midwifery. By the 1950s, the numbers of these new nurse midwives had increased significantly, such that an organization was formed to provide some structure to their existence. So in 1955, ACNM was founded to provide structure, to provide a means, some standard, a means of certification for this growing field of midwives, nurse midwives. And by the 1970s and 1980s, ACNM received a significant boost in its membership. The membership grew exponentially, and but they were still negotiating their autonomy, the kinds of services, maternal health services or reproductive health services that they could offer to women, and the services that they could provide independent of or in collaboration with doctors. And it was under this circumstance, under this condition, that they made the decision to venture abroad to create the special projects section. And part of the idea was a recognition that the status of midwives and midwifery in the United States was tied to a global status of midwife. Now, the special projects section, one of the major goals of SPS was to combat deteriorating maternal and infant health, to improve the lives of women, and to advance the field of midwifery. And a lot of their work was focused abroad. All of their work for the first decade of their existence was focused abroad. And in the 1980s, a lot of this work was on the African continent and also on the Asian continent. And on the African continent, their focus was on Anglophone countries in Africa. These were countries that were former British colonies. And so they spoke English. And there was a good chance that they also would have US presence and US connection due to that British tie. Now, they also focused their projects on countries that were economically significant, that were also significant population-wise. And one of those countries was Nigeria, which had always had strategic interest to the United States, especially in terms of the Cold War politics in the 60s, 70s, 80s, after Nigeria gained independence. They also cited a lot of their work in Ghana, which they identified at the time as the third largest country in West Africa. And elsewhere on the African continent, a lot of their projects were in Kenya and Uganda. These were two major East African hubs. Now, ACNM's interest in Nigeria as one of its sites for intervention did not exist in a vacuum. Before they showed up in 1982, there were already a number of US organizations active in Nigeria and providing population-related services. And these organizations, the US organization presence in Nigeria began shortly before Nigeria's independence, around 1958, as a result of mostly of concerns regarding population. In the middle of the 1950s, there were concerns, especially in the Rockefeller Foundation, that global population dynamics were changing, that the population of the Western world, apart from the Soviet Union, was declining, but the population of the so-called third world, newly independent African countries and independent countries elsewhere in the world were increasing. So there were Malthusian and eugenicist-based concerns over this pattern of population growth. But there was also concerns about the kinds of economic implications that such population growth would have on the world. There was this idea that by the 1980s, a projection that by the 1980s, there would be an end of the world kind of repercussion if population was unchecked. So by 1958, and definitely throughout the 1960s, US organizations, including Rockefeller and the Population Council, which emerged as a product of a population-related meeting that Rockefeller Foundation hosted in the 50s, began to do work related to population control in Nigeria. And they specifically singled out Nigeria amongst other countries because of the size of the country. It was the largest on the African continent population-wise. It was also important to the United States strategically. There was a lot of work on population related projects. There were also population labs, demographic labs that were set up by US universities, including Johns Hopkins University Population Labs. And what these organizations did was to begin to collect and to train Nigerian institutions to collect demographic data and to collect health indices as well. And it was under this environment that ACNM began its work in 1982 in Nigeria. Unlike the organizations that existed that were active in Nigeria before them, a lot of the focus of their early projects were around family planning services. I just mentioned that, that there were population control projects, which eventually culminated into family planning projects in Nigeria already. But part of the problem was access. And this was where ACNM's intervention came in. These family planning services were not accessible to a bulk of the Nigerian communities. And part of the problem was the ways in which postpartum care was structured in the country up to the end of the 1970s. Postpartum care was required for women with complicated deliveries, but it was not expected or required for women who had normal, uneventful deliveries. Now, what that meant was that family planning sponsors and family planning practitioners lost that chance, the opportunity to offer to women who had just had babies and who would visit the hospital for postpartum visits, to offer these women and their families family planning options. But there was also an issue of personnel. Nigerian doctors at the time were stretched thin compared to the number of people that they had to serve. So they could not take on, in many cases, the family planning clinics. And part of ACNM's proposal was to empower midwives, including private midwives, which Nigeria had in abundance, to actually take care of these the family planning programs, to train midwives to take charge of the family planning clinics in order to expand access. And after a pilot program at the Lagos University Teaching Hospital was launched that kind of tested out expanding postpartum programs to the entire population, all birthing women, ACNM began to work to empower midwives to take charge of those postpartum clinics and also offer family planning services as well. Then there was the issue of maternal deaths, maternal mortality, which was also part of the challenges and part of the issues that they took on. One of ACNM's criticism of the organizations that existed in Nigeria previously, before they joined with their work in Nigeria, was that the projects focused almost exclusively on family planning. And there was very little attention to maternal deaths. But by the 1980s, Nigerian doctors and the Society for Obstetrics and Gynecology in Nigeria had begun to raise awareness regarding the extent of maternal deaths. The data had emerged, especially as a result of all of the demographic works and the works by the population labs in the various institutions about the extent of the problem. And the Society of Obstetrics and Gynecology used these data to estimate the extent of deaths at about 75,000 annually in the country. And this was consistent for most of the 1980s.
So one of the projects that ACNM took on became to highlight internationally the extent of the problem, but also to create projects that addressed the issue. Because the Nigerian government could do very little or would do very little at the time, because Nigeria was in an economic crisis, an economic recession in the 80s, and the federal government had just slashed the national budget, the health national budget allocated to health. And so there wasn't enough for health, and there certainly wasn't enough that they were willing to commit to prioritize women's health. So ACNM stepping in helped in amplifying and drawing international attention to the need to fund programs in this regard. And I'll talk about that project in a little bit. But one of the things that they also focused in on was elevating the status of midwives, not only in Nigeria, but internationally, because they realized that for a lot of their projects on maternal health to succeed, and a lot of the push to utilize midwives as a source of reproductive health care to succeed, the status of midwives needed to be improved globally. Now, one of the techniques that they adopted in doing so, in trying to change global public health ideas surrounding the use of midwives for reproductive health care, was to show films such as All My Babies. This is a film that most historians of medicine in America are going to recognize. Now, All My Babies was a film that was produced in 1953 by the Department of Health in Georgia. And this film tracked the professional journey of this popular Black midwife who had delivered over 3,000 babies in Georgia. It tracked her delivering babies under ideal conditions and under far less than ideal conditions. And so this film was a training manual, if you will, on what the services of a lay midwife should look like and how a lay midwife should attend to deliveries in under different circumstances and under different conditions. They began to show these films to governments, to international agencies, and at international conferences to push for and to make an argument for what the services of midwives would look like, especially in low resource setting. Another film that they began to show that served dual purposes for them is this film Wibambwe, which essentially means traditional birth attendants. This was a film that was created in Congo, then Zaire. And this film basically chronicled the experience of developing training programs and supervisions for traditional birth attendants. One of the push that ACNM was making was to empower traditional birth attendants across the African continent to be utilized as a means of providing maternal care, especially in low personnel setting and in low resource setting. And this program in the Congo, what they filmed in the Congo was a pilot program. And they filmed it to show what a TBA service, what a traditional birth attendant service would look like, what the supervision would look like, what the training of trainers would look like, and what the collaborations with doctors and with hospitals would look like. This film served a dual purpose. On the one hand, it was one of the films that they had in their tool bag to convince global health agencies, including the World Health Organization, different agencies in the United Nations, about the importance of training and utilizing traditional birth attendants within their own communities. But they also used it as a public health tool to highlight to the world, to ACNM members, and to various groups at home in the US, the nature of ACNM's international work.
Now, as a result of a lot of the international canvassing that they did, along with the work that they did in collaboration with the International Confederation of Midwives, in 1987, at an international conference in Kenya, the Safe Motherhood Initiative was formally launched and support and with the sponsorship of USAID, the World Health Organization. And the birth of a formal movement further empowered ACNM in its projects and in the kinds of mandates that it received from national governments, including the federal government of Nigeria. Shortly after the creation of the launching of the Safe Motherhood Initiative, ACNM began to develop a particular project that was specifically tailored at addressing maternal deaths. The two projects that I have on the screen, the Mother Care Project and MAPS, were two of the major projects that they undertook in Nigeria. I'm not going to go into details about MAPS because I already talked about it without naming it. This was the project that they started with, the project that had to do with expanding access to family planning and training midwives, strengthening midwifery associations, creating them where they did not exist, and just empowering midwives to provide family planning services to women across the country. But the Mother Care Project, which I will focus on, was specifically targeted at addressing the problem of maternal deaths. And this was a very comprehensive project that had different dimensions to it. It involved the recruitment of key local stakeholders, religious leaders, community heads, women's organizations, NGOs, in trying to raise awareness around maternal deaths and around the dangers associated with pregnancy. It also involved training traditional birth attendants and clinically trained midwives to improve their knowledge, upgrade their knowledge and their skill so that they could respond better to obstetric emergencies. Now, the part of the project that excites me most is the mass education campaign that it involved. This project took the form of a mass education campaign that it involved TV shows, radio shows, magazines, all kinds of drama series in national televisions and in local television. And one of the strategies that ACNM adopted was a strategy that had already been mapped out by the Society for Obstetrics and Gynecology in Nigeria, which divided the country along 4 health zones. There was a health zone in the eastern part of the country, in Enugu. There was another health zone in Ibadan, in the western part of the country. And there were 2 health zones in northern Nigeria, in Kaduna and Bauchi. And they cited their pilot projects for the Mother Care projects in these health zones. And one of the things that they did as a way to raise awareness was to bring in representatives of international agencies to visit the sites of their work to raise awareness on the problem, but also on the need. Now, I'm highlighting a magazine, Atoka, that featured prominently in this project. Atoka is a popular Yoruba photo drama magazine that was in print beginning in 1967. And I highlighted number one because I could find an image for this particular magazine. And then secondly, in the ACNM records, they actually took the time. There was a lot of buzz and excitement around Atoka, and they discussed Atoka extensively. And one of the things that they did with Atoka was to get the producers to determine various themes around maternal health, around maternal deaths, around pregnancy, and turn it into a drama. Now, Atoka was very popular in Ibadan and in Western Nigeria in general. And it was a magazine that was created in Yoruba. And the way that it worked, if you look at the screen, the picture to the far right, the way that it worked was that the producers actually did a a drama series, recorded the show as you would record something for TV. They recorded the drama, they filmed the dramatization of whatever subjects that they'd chosen, and then they created still pictures from those films and laid it out in magazine format, as you can see to the right. And then they had dialogue boxes, and they will insert the appropriate dialogue next to the still picture. And this particular platform was very popular. It was an informal and highly dialogical space for public discourses. And just like there was a talker in Ibadan, they identified other very public platforms across the country in the other health zones. There were other magazines, there were radio shows that were specifically targeted at particular audiences. There were shows that were targeted at men. And a lot of the research that they did before implementing this project was to determine what media platform each of their target audience listened to. So in northern Nigeria, for instance, they created radio shows and talk shows that were directed at men, because part of what they came up with in their research was that the men had the radios, the men listened to the radios, and they created others that were targeted at women that will actually reach the women. And the general messaging in all of these media campaigns, like there was music, they hired musicians, they sang jingles, they hired musicians to sing songs related to maternal deaths, related to pregnancy, to generate public discourse on the subject. The messaging in general was surrounded the increase of knowledge of danger signs during pregnancy. This was some of the points that they identified in their research. It also involved increasing awareness of cultural practices that endangered pregnancies, because from their research in the different parts of the country, in the different health zones, there were particular practices specific to those parts of the country that were actually dangerous to pregnant women. And they put out messaging that addressed those things and that generated public discourse around those subjects. And then there was the issue of blood donors too. Across the country, one of the trends that they found was that the belief that blood donation could affect the donor. And so there weren't a lot of blood supplies in the blood banks. And one of the leading causes of maternal deaths in Nigeria, in the United States, across the world, was hemorrhaging, and still is hemorrhaging. So in the case of Nigeria, when a woman was hemorrhaging during childbirth, in many cases, unless there was a relative who matched and who was willing to donate blood, then chances are that that woman's life was in grave danger because of lack of blood in the blood banks to be used to keep up with her maternal health care. So a lot of the messages surrounded blood donors as well. Now, the mother care projects had a very significant impact in Nigeria, especially in the 1990s. The first part of that project started in 1991 and lasted until 1994. Now, one of the major impacts that it had was in drawing international support to the local efforts to curb maternal deaths. Again, part of the strategies that ACNM adopted, and it was interesting to read the dialogues in some of the documents where they were basically planning to figuratively drag USAID officials to the project sites, to the mother care sites, to force attention to the issues and to shift USAID focus, even in the 90s, on family planning and on the voluntary sterilization programs that they were sponsoring. So there was this big push to create international attention surrounding the problem of maternal deaths and to attract funding to deal with those problems, to expand the programming that related to maternal deaths. But another thing was the proliferation of TV programs. I mean, the 90s was an era of great public discourse and public awareness on the issue of maternal deaths, on some of the dangers surrounding pregnancy. This was an era where it was common for international organizations, health organizations in Nigeria, to hire musicians, popular Nigerian musicians. A lot of Nigerians will recognize Onyeka Onwenu. Onyeka Onwenu, King Sunny Ade, these were musicians, very popular musicians that were hired to sing songs related to reproductive health and generate public discourses around those subjects. The airwaves locally and nationally were flooded with conversations around pregnancy, conversations around reproductive health in general. And there was increased awareness and dialogue surrounding some of the cultural practices that affected pregnancy. And so the 20th century closed out with a lot of public awareness and conversations, at least in the major cities in the various parts of Nigeria with the health zone, but also at the national level. And this is an effort that has not been matched since the 21st, even in the 21st century. Now, I want to conclude by pivoting back to the United States. In the mid-1990s, ACNM became interested in developing special projects in the US. But one of the things that they quickly realized was that they had not cultivated their domestic networks as they did their international ones. And so they needed much more work to make inroads with implementing special projects at home. Now, part of the problem was also the potential pushback that could come from within the organization and outside of the organization for adopting what they described as overseas model at home. There was the concern, as you can see from this quote and the rest of the document, there was concerns about pushback of associating particular models that were implemented in third world countries and in countries that are supposed to be better than the United States in the United States and what that meant. Now, how this effort played out is outside of the scope of my research and my presentation, but I bring it up and I end on that note because I do want to make a point about what we, particularly the US, can learn from Africa and other developing worlds in the fight against maternal deaths and in the shortcomings of reproductive health care, especially in terms of the collaborative approach of the work that ACNM did in Nigeria to tackle the issue of maternal death. The extent of the mass media campaign and the collaboration with the government, with advocacy groups, with community leaders, and with the community itself to address the issues and to generate conversations around the ways to approach the question of maternal death. But there's also the question of the decolonization of healthcare and healthcare infrastructure, especially considering that most of the efforts at fixing maternal health care, as we can see in the examples that I gave, has involved the return to various models and systems, for instance, traditional midwives and traditional birth attendants that were disempowered, criminalized, stigmatized during the colonial period and carrying over into the post-colonial period. So what does that mean when we think about healthcare infrastructure and what is legitimate healthcare and what kind of healthcare is suitable for people, but not for others, for the Western world, but not for the other parts of the world. And I'd like to stop on that note. Thank you for your time, and I look forward to further interactions in the Q&A.
Thank you, Dr. Williams, very much for your fascinating talk. We do have a number of questions, and I'm going to get right to them because they are excellent, as was your talk. Thank you for this wonderful and informative talk. You began by noting that midwifery was illegal in the United States in the early 20th century. My understanding, this person writes, is that the reason behind this restriction was, at least to some extent, the professionalization of medicine and the idea that only graduates of accredited medical programs could practice any type of medicine. Has this professionalization bias emerged in other parts of the world as the number of licensed physicians increased? Has there been similar resistance to midwifery and other care providers?
That's an excellent question. And I'm going to use the example of Nigeria to answer that question. I'll answer that question in two parts. On the one hand, traditional midwives always existed in Nigeria. But during the colonial period, which was the first half of the 20th century, the same pattern, the same thing that played out in the US, a similar thing played out in Nigeria as well, but perhaps for different reasons. Traditional midwives became stigmatized, became stereotyped, and in many cases, for good and fair and bad reasons, were blamed for deaths, infant deaths, for maternal deaths. And at the head of this push were missionaries. Missionaries had their own agenda. First of all, missionaries saw childbirth as an opportunity to Christianize. To one of the quotes that I have in my head, and I'm not going to quote it verbatim, but the logic was that offering the services of offering aid to a woman during labor and delivery was a good way to actually gain access to the woman and gain access to her family, because then there was a good chance that the missionary doctor or a missionary official who was offering this service would be able to baptize the baby, would be able to convert the woman, and through the woman would be able to have access into her network and into her community. And one of the things that they did very clearly was to identify traditional midwives and other traditional practitioners as the obstacle, as their obstacle to this Christianization, as the people who upheld the traditional structures and the religions, elements of the religions that they were seeking to uproot. So there were significant efforts to then stereotype midwives, to stereotype midwifery, to get them out of the way, to get births into the hospital. And this was partly successful, but partly not. Because what happened was that then women began to go to the hospitals for the prenatal visits, or what the British world will call the antenatal visits. But for delivery, they went home and they delivered with their midwives or with their family members. So there was that dimension to it. And then there was the element of the British colonial government as well, which privileged biomedicine and biomedical enterprises. And of course, a lot of the framework had already been set for by missionaries, because for the first 20 years or so of the 20th century, the first 30 years actually, between 1900s and 1930s, the colonial government pretty much ignored women's health. So it was largely work by missionaries until they decided that women's health was important in terms of labor supply, in terms of successful childbirth, living children, and protecting the labor supply within the colonies. And so what happens from there is that there were more moves and more policies to disempower midwives. There was briefly a conversation about training, just like we talked about with the TBAs, training traditional midwives or the bush midwives, upgrading their knowledge to utilize them, because it was impossible to provide services to the whole of the country, to the rest of Nigeria. But that idea did not materialize. That idea was dropped. And there was the push to just make childbirth a medical thing and an event that happened in the hospital. And that became the trend. There was a general stereotype and stereotyping of traditional medicine, including traditional midwives. And this practice carried over into post-colonial Nigeria. But then when it comes to clinically trained midwives, that was a different development. This was part of the biomedical framework. And Britain, like different parts of Europe, most of Europe did not outlaw midwifery. Midwifery became a part of the biomedical care setup. The same thing played out in colonial Nigeria. If a woman had enough education to train as a midwife or as a nurse or a nurse midwife, then that's what she became. So there were clinically trained midwives who were offering services, but there were also traditional midwives who were largely sidelined, and there were efforts to push out. Those efforts were not successful because just like in the US, in a lot of the rural communities and different communities in Nigeria, it was the midwife that was their only recourse. Hence, ACNM's effort, again, to retrain or to train these women to upgrade their skills and to train traditional birth attendants in general to be able to deal with obstetrics complication because they were what their communities had, literally.
Thank you. Thank you very much. Another person has written in with thanks for your wonderful talk. I'm really interested in learning more about ACOG and that genre of publication. I have seen something similar in East Africa. Was part of the appeal of this medium that a project created in one language could be reproduced with the printed dialogue in translation for a variety of communities? In other words, were there efforts in these projects to create tools that would be more universal or at least regional, or did they focus on tailoring resources and messages to specific local communities?
I am also interested in ACOG, and part of my efforts right now is to track down as much of them as I can, especially during the window that ACNM was, the Mother Care Project was active. But what I can tell from the documents that I've reviewed is that the messaging, there wasn't necessarily an attempt to make the messaging universal. Those messaging were targeted to those specific audience, especially because in a place like Nigeria, with its multiple languages, like the different health zones that I described, the 4 health zones, they had 3 different languages. It was Igbo in the east, it was Yoruba in the west, it was Hausa, Fulani and Arabic in the north. And so the languages didn't necessarily speak to each other. These were distinct languages. So with Atoka, which was produced in Yoruba, it was specifically directed at that Yoruba community. And the way that the Mother Care Project operated, the issues that were printed in Atoka or in Ilela Rolo, which was another popular health magazine, I just couldn't find a reliable image for that one, or the messaging that they put in those particular medium or in the radio shows in the North were tailored to the problems that they identified in those particular areas. For instance, in the North, one of the issues that they had to deal with was a particular kind of female genital mutilation that occurred during childbirth, especially with first pregnancies. In the West, one of the problems that they specifically dealt with, the messaging that they pushed out, had to do with the avoidance of eating certain foods like leafy greens or eggs. So these messagings were tailored to those particular audience. And so the various medium that was chosen also reflected those messagings and the locations where those messages were being pushed out.
Thank you. So there are 2 questions that are somewhat related, and I'm going to ask both of them as a way to frame this. So both of these individuals, thank you very much for a great talk. The first individual writes, I wonder if you can talk a little about how, if at all, the ACNM affected birthing practices and maternal mortality outcomes in Nigeria? And the second question, I'm wondering about the tensions and/or convergences in ACNM programs between the eugenics agenda of combating so-called overpopulation and the public health agenda of preventing maternal deaths and encouraging healthy motherhood.
Okay, I will start with, I will answer the last one, and I might ask you to remind me of the first part of it.
Very good.
But the tension between, the eugenicist aspects of public population control and regulating or controlling maternal deaths were not just local in Nigeria. This was not just happening in ACNM. So by the 1980s, there was this national development in the population control movement itself. 1980s, especially as a result of a lot of the data that had been generated as a result of that work related to tracking population, tracking health indices, the extent of the nature of maternal deaths had become obvious globally. And so women's organizations and members of all of these organizations that were also doing population-related work mounted a revolution, if you will. They began to push back on the extreme focus on population control, the focus on family planning programs at the expense of maternal health or maternal death in terms of improving the outcome of pregnancies. So ACNM was a part of this conversation. This was a trend, a global trend across the world, where the new kinds of people in these organizations began to push for a look at maternal health care and an approach that did not just focus on family planning, that actually focused on the survival of women during childbirth, during delivery, or during postpartum. And the first part of the question talked about whether ACNM projects affected maternal death outcome.
Birthing practices and maternal mortality outcomes, yes.
Maternal mortality outcome. Now, this is something that I haven't looked at yet. One of the things that I hope to do as my project progresses, is actually to look at whether there are any statistics pointing towards what maternal deaths, what the numbers looked like. We know a little bit of what the numbers looked like in the 1980s because the Nigerian doctors, the Society for Obstetrics and Gynecology in Nigeria were talking about it, and they were drawing attention to that. I also know from what I've found so far that the Ministry of Health in Nigeria under Dr. Ransom Kuti, the brother of the famous Fela that most people would know, he was the Minister of Health at the time, towards the end of in 1989, 1990. One of the things that he implemented was to require hospitals across the country to actually report maternal deaths to the federal government. There was an effort by the ministry to collect statistics on maternal deaths, but also information on the causes of maternal deaths. Now, what I don't know and what I'm trying to find out, part of the data that I'm trying to get a hold of is those data. What was submitted, what was collected, what kind of picture that it painted. But right now, I haven't tracked what the outcomes were in terms of the numbers. And at that point, Nigeria had not gotten good at recording. I mean, this was a country that gained independence in 1960 and fought a war in the 60s. And then in 1970, the war ended. And then there was a recession in the 1980s. So it was struggling to catch its breath. And it had had different change of governments by way of military takeovers, military dictatorships. And so the collection of numbers was not stable, if you will. those datas were not stable. And it got better in the 21st century. In the early 2000s, Nigeria began to release numbers consistently every year that tracked these things. Now, what I do know, though, is the cultural impact that ACNM projects, as well as the projects of some of their partners also working in Nigeria, the fact that a lot of conversations were being had. Now, you have to design a research to track those impacts, but there were public discussions in a way that never happened previously on maternal health, on pregnancy, on some of the danger signs, how to recognize the danger signs, and the dangers of certain cultural practices. And this is where Atoka and all of these other magazines and radio shows came in. There were discourses to the extent that had never been had previously and had never been had since then either. So that's the best way that I can answer that question right now.
Thank you. So we do have time for one more question, and it does pertain to those sources that you're alluding to that were part of the public dialogue, the television programs and the videos. And the question is, to what extent, beyond what you've presented, do you have a sense that these materials still exist? Have you had challenges finding them? To what extent were they ephemeral and not available for research now?
The simple answer is that we will find out. I have started efforts to track Atoka, for instance, especially copies from between 1989 and as long as, because Atoka did go out of print shortly after, not too long, in the 90s. So I'm trying to find the copies from 1989 until they go out of print. And one of the good sources to find things like this, because these were magazines, public documents, and archives in Nigeria, university archives in Nigeria, but also the national archives tend to have magazines, things like that, popular magazines in their collections. So the next time that I have the opportunity to do archival research, one of the things that I'm going to do is to look at those university archives, those local archives within the region. Ibadan, for instance, where Atoka, one of the places where Atoka was popular, has a university and the university archive as well. And there's a good chance that those will be there. And then there's also the question of crowdsourcing. Ilera Rolo, for instance, the Health is Wealth magazine, it is possible that there are individuals who may have kept copies of that as well. I mean, we're talking about the 1990s. So there's a good chance that those will also be in private collections. So I'm going to find out how accessible these things are sooner or later, because I didn't know they existed until I started going through my records at the National Library of Medicine. And I found out about the existence of Atoka and some of the projects that ACNM did with Atoka just about 2 months ago.
Well, Dr. Williams, certainly if we can be a further resource for you at the National Library of Medicine, do be in touch, and we look forward to welcoming you back when you can return. And on behalf of the entire library, I'd like to thank you very much for a great lecture that you offered today, the 8th annual Michael E. DeBakey lecture. And we wish you every continued success with your research and your writing, and certainly your second book. Look forward to reading it.
Thank you. Thank you very much.
Thank you. Have a good afternoon.
Thank you.
And
thank you, everyone.
Thank you. Thank you. We'll keep in touch. So before we say a formal goodbye, I'd like to thank everyone for tuning in to this wonderful NLM History Talk, and certainly for your participation in all of our talks during the course of 2024. Our 2025 series will be announced early in the new year. And in the meantime, and certainly thereafter, and as always, do be in touch with us if we can be a resource for you at the National Library of Medicine. We look forward to being such a resource, and we welcome you to visit our website at nlm.nih.gov to learn more about the collections and the resources that we offer to support research and as well answer health-related questions that you may have. So again, thank you very much. We wish you a good day where you are and look forward to seeing you in the new year. Thank you.